All right, so Christine is going to do a presentation today, 40 below and 70% diverted, which is a little cold for me, right? But the folks in Alaska are used to it, and talk about their system there. So I'm very excited about that. Let's go to the next slide. All right, so this is the overview of participants in this weekly Crisis Jam learning community. We are holding steady at about 11 Medicaid offices. So if your state is not highlighted in red, feel free to send the invite to your Medicaid folks to have them join us. And I'll tell you how to do that in just a little bit. The other thing I want to note is that this learning community is very diverse in terms of lived experience, peers, state and local legislators, PSAPs, hospitals, courts. So I think that helps us have more robust learning. So feel free to invite other colleagues, folks you may know. We really want to hear from them and benefit from their experience. So let's go to the next slide and I'll tell you how to send the invite to people who may not be a part of this learning community. It is right here. As soon as you go to as soon as you go to talk.crisisnow.com, you will see a Zoom link, and you can just copy that link and send that to your Medicaid office or other folks that you want to join. We try to make it easy for you to see past videos of the jam, sign up for the newsletter. If we go to the next slide, we've also broken out a lot of the segments here. So the crisis trivia, the crisis cards, you can easily watch the video. So they try to make it easy for you. So again, it's talk.crisisnow.com, and then we can make sure that everyone is participating. All right, so the quote for this week comes from Dr. Tom Unsel, and it is a quote from his chapter in the Fixing Crisis Care book. And so it's homelessness is by itself stressful, dangerous, and unhealthy. Add mental illness either as a cause or a consequence, and you have a modern tragedy, which I think is very poignant and points to the work that we all want to do and see as we make crisis services more accessible to folks and making sure that we're thinking of the needs of people who are unsheltered. So let's go to the next slide. And this just piggybacks off of this. This is an article from the LA Daily News back in January. And this is about a community called, I believe, Safe Landings. It is a no barriers, you can bring your pets if you have a medical or physical issue. They have 176 beds. It is 136,000 square feet. And this was just recently, I believe, opened or at least built, if not open yet. So definitely something for us to keep our eye on. Next slide. And then, of course, we are seeing as we're getting closer to that July 2022 launch for 988, lots of articles coming out, both from USA Today and the Washington Post. So very excited for 988 to be amplified. Next slide. And then again, this is a ABC News piece about 988, in particular, the funding component and the introduction of the 988 Implementation Act, which does include funding authorizations both for the Lifeline and local crisis centers. And so I know we have Dr. Eric Raffalayan on here later to talk about this, but just wanted to, again, highlight the importance of this legislation and coverage. All right, so with that, I'm going to turn it over to Christine Alvarez to talk about the mobile crisis teams in Alaska. Thanks, Christine.
Great, I'm thrilled to be talking about this. It's the first mobile crisis team in Alaska. You can go to the next slide. All the pictures are taken from Alaska. So you'll get to see the beauty of it. So this is a picture of some of the peers and the clinician on the mobile crisis team. If you notice the boots all the way to the right, those are extra tough. Those are for sure Alaskan boots. So wanted to get that in there as we're talking about the mobile crisis team. You can go to the next slide. So we are really about 5 months in as far as providing service. It's very new. June or July, we began hiring staff. We did the training. We developed policy and procedures. We did ride-alongs. And then in August, we continued to do some of that asynchronous crisis training. We reached out with stakeholders. We did ride-alongs with the Fairbanks Police Department. And then in September, we did a synchronous crisis training with the entire staff. That was about 40 hours. And we also continued the outreach, but then in October, we did the soft launch. It was just Monday through Thursday, 7 a.m. to 7 p.m. and on weekends. And then in November, we expanded the radius. So we are now doing the city of Fairbanks, but also to include the University of Alaska Fairbanks area. And we are 24/7, which is very exciting. Next slide. So as many of you know, but the essential functions of the mobile crisis team really to do that triage, screening, assessment. We provide peer support. That's very important as part of our mobile crisis service. We really focus also on de-escalation and resolution and coordination with medical and behavioral health services. That's so important. And then we collaborate with families, natural supports, we provide information, we give referrals, and then we really do great crisis planning and follow up with everyone that we engage with. Next slide. So the staffing, we include a licensed or master's level clinician and a certified peer support specialist. We really feel like that team is essential to providing mobile crisis services. We respond in the community. We don't restrict services to specific locations or days and times. So it's the right care at the right time in the location that the person is experiencing the crisis. That's so important. Surprisingly, our busiest day is Wednesday. A close second is Sunday. And the MCT, which I'll talk about in just a little bit, often responds without law enforcement accompaniment, unless obviously the situation warrants inclusion. But generally, most of our responses have been without having law enforcement present. So we adapted our dispatch levels from the Georgia Department of Behavioral Health and Developmental Disabilities. Their guide came out, and it's using mobile crisis services in lieu of an order to apprehend. And it's really interesting the way that we've incorporated it, and we're still kind of seeing if this is long-term what we want to do. So there are 5 levels. The first level is really where the law enforcement leads. So what happens right now is a call comes into 911 and 911 is dispatching the mobile crisis team. Caroline is not doing that quite yet. We're building up that infrastructure, but in the meantime, we're being dispatched by 911. So they will receive the call. And this is really where law enforcement needs to be the primary responder. So the MCT must follow police instructions and respond to the scene once it's safe for entry. This level is really for situations that just are too dangerous to deploy an MCT team, and the environment needs to be secured by law enforcement. So that's really our level 1. You can go to next slides. You know, this is MCT on level 1 would never be dispatched alone because this is really where there is, again, I talked about having a secure location, but also there's imminent danger. So likely or very likely intent for a suicide attempt, likely or very likely intent for a homicide attempt, a threat to staff, possession of weapon. Again, so law enforcement is leading, MCT is standing back and is waiting for it to be cleared for them to step in and then provide those services. Go to next slide. So level 2 is the mobile crisis team leading, but law enforcement is still present. So these are situations where the MCT staff enter the environment first, but law enforcement is immediately available if needed. So this would be if there's a significant history of aggression or recent acts of aggression or potentially self-injury. So again, this is not MCT alone on level 2, but if MCT is taking the lead with the support and the backup of law enforcement. Next slide. 3 is MCT Lifeline. And in the next line, I'll describe what urgent cases mean and emergent cases. But again, this would be MCT going in The police are available via phone and standing by, but they are not physically present when we're responding. Level 4 is more of the urgent cases, which I'll talk about, and that is MCT alone. They obviously can reach out if they need assistance, but law enforcement isn't on standby, isn't waiting. And then level 5 would be a secure location. So this may be if the hospital calls, or there's a place where the peer may not come. It may just be the clinician. We don't need to necessarily have that 2-person team for safety. And this may be, we don't get a lot of these calls, but there are a few. Next slide. So when we're talking about level 3 and level 4, this is really what I mean when it comes to acuity. So in an emergent situation would be a life-threatening condition, suicidal, homicidal intent, active psychosis, active withdrawal, disorganized thinking, imminent danger, unable to care for oneself. So emergent will probably be level 1, level 2, and some level 3. And then you have urgent, and on these urgent calls, that's usually just mobile crisis. So no suicidal, homicidal intent, denies suicidal plan, means, expresses hopelessness, helplessness, sense of burdensomeness, disconnected, anger, may develop suicidal intent, may have some withdrawal signs and symptoms, but from non-life-threatening substances. So again, the urgent is really more of where the mobile crisis team responds alone. And that's usually sometimes a level 3, sometimes a level 4. Next slide. It's different. So I've done mobile crisis in Austin, Texas. And so I was not dispatched by 911. And it's just a really interesting way that we've adapted to do mobile crisis for a system that's already established. And one of my crisis clinicians that's from Colorado said that, this is just a quote, being dispatched by the emergency dispatcher is definitely different. And I'm thankful for this, as they get a lot of information that helps keep us safe. I also like that they know where we are and that they call us every 30 minutes to make sure we're okay. I feel connected to a safely lifeline, makes doing the job easier and less stressful. What happens is we're connected to the CAD, and so they're able to GPS track the mobile crisis team. They're regularly checking in if they're not responding. And so it's really been exciting to kind of see that the way that the mobile crisis team has been incorporated into that emergency system. Next slide. So here's the data. Again, we're just 5 months in, so I know it's not a lot of calls, but it's actually, for how large Fairbanks is about 30,000 people. So we've had 223 calls, 161 unique individuals unduplicated. Average time is 28 minutes from call to on scene. And then the average time on scene is 53 minutes. We've done a total of 210 follow-ups. So our clinicians and peers take the calls, but they also do the follow-ups right now. And that's how we've been able to make it work in a more rural environment. Next slide. This outcome is just so exciting for me. So we are hoping for 70%, and that's what we have in the title. But as we've been doing this, we're now at 88.5% that we've been able to maintain in the community. 9% have gone to a higher level of care, the hospital, and 1.5% have been the police. So we are really, I feel like we are doing something right, and we're really making a difference in our community. So it's just been so exciting to kind of see this unfold as we've been providing these services. Next slide. I wanted to just help you understand the breakdown. So what you can see here is that, sorry, my chat is getting in the way. 76.7 were resolved without involving law enforcement. So, level 1 and level 2, that's law enforcement is either leading or they're backing up, right? But then you can see the level 3s, level 4s, and level 5s, how much we've been able to meaningfully engage with individuals that have called 911, where we don't have to include first responders, and we're able to let them do the job that they need to do, and we're able to effectively de-escalate and meaningfully connect with individuals. So I'm thrilled to be able to see what we've been able to do. Next slide. Here's the breakdown in ages. You can see the most individuals that we're connecting with are those between the ages of 30 and 39. And so this is, it's just helpful to look at. Yeah, so we can move to the next slide. I know I only have 15 minutes, so I want to honor the time. Interestingly here, so when you look at the demographics for Fairbanks, about 8% are Alaskan Native. So we're disproportionately serving that population. And then you can see the other breakdown. So it's just helpful to know the population we're working with. Next slide. Stories. So there are just two kind of stories I wanted to talk about. One, a client was suicidal and he planned to shoot himself with his gun. Police were called to the home. The mobile crisis team was able to talk to him over the phone, discussed putting his gun away and meeting with him without the weapon. He ended up putting the gun away, meeting with the MCT, and was transported to the hospital. So what an amazing opportunity to connect with someone in that moment of crisis and to get them where they needed to go. The next slide. Then another one, they were called to the homeless shelter, and there was a woman that was engaged in a pretty intense conflict with another resident. She had a previous history of schizophrenia, and the mobile crisis team was able to de-escalate the situation, link her to a psychiatric provider and clinician. She got back on her medication, and she'll be moving into a new apartment soon. I mean, this is the heart of what we do. I was going to title this slide, Why We Do What We Do. And I think that it's so important to get individuals what they need so we can be able to help them stabilize and engage in recovery and be able to get housing or whatever resources they need. So these are just two small snapshots of the amazing work that the mobile crisis team is doing in Fairbanks. I see some questions here, but I don't know the time. So
Christine, we can play a little fast and loose with the time. I think this is a great presentation. I was just really stunned to see less than 2% are going to jail or otherwise with the police. So I think that kind of diversion from the criminalization of crisis is fantastic. And 88%, I think it was, being served in the community. Before we turn to the roundtable and get to some of the questions in the chat, I just, a couple of things stood out to me, and I wanted to see if you wanted to speak to any of the special supports that may be provided to the Alaska Native population.
Yeah, so we will, so we have, I can't speak specifically to this because I'm not in Fairbanks right now, but there are tribal, sorry, I keep getting the chat through. So what we do is when we do mobile crisis is we're very intentional about care coordination and connecting individuals to so some will come to our agency, some will go to the tribal organizations in Fairbanks. And so we're very, very focused on making the right connections to the resources available in the community.
Great, and I think that was part of my next question around coordination and connection come 988. So let's see if we have just one or two questions from the chat before we turn it over to our roundtable. I see a question around veteran crisis services. Not sure if you want to speak to that or consent with follow-up.
So what we usually do for follow-up is we do it 24 hours and then 5 days and 10 days. So we kind of have this standard, but if someone needs it, every 24 hours, we do that as well. We obviously, if someone is able to be stabilized with initial crisis assessment and they do not want follow-up, and we're able to effectively safety plan and give them the resources, then we won't follow up. I mean, they have the right to engage and to decide to not engage anymore. And so it's really based on the safety planning and then their level of desire for engagement.
Okay, I'm going to turn it over to give our roundtable speakers some space to tell us their thoughts. So I'm going to turn it over first to Dr. Richard McKeon, who's the chief of the Suicide Prevention Branch within SAMHSA. Richard.
Great, thank you. Thank you very much, Laura. Really appreciate it. And thank you, Christine, for a great presentation. Wonderful to hear about the work taking place in Alaska with this mobile team. So, a couple of thoughts that I would share. So one is that, SAMHSA is very engaged in suicide prevention in Alaska. We have dozens of suicide prevention grants within the state, many in very remote areas. And so that will present certain challenges for mobile crisis, because in many places in Alaska, there's not roads to get to them, and you can only get there by plane or by boat. And one of our staff in the suicide prevention branch, Angela Mark, has worked to annually go up to some of these remote villages. So what that means is that you need to have a mobile team already embedded, and that's probably only going to be possible in some of the cities like Fairbanks, like Juneau, Anchorage, obviously, but not the kind of more typical model where we might think that some more remote communities could be accessed by road, perhaps with a longer time to get to them. That model would not work. So it'll be really important, to think through, but particularly for Alaska, because it is so unique in that regard, about how to meet those needs outside of the areas like Fairbanks, Juneau, Anchorage. But I just love the work that is being done there. I think that, what we're hearing about in Fairbanks, the emphasis on defining criteria, mobile crisis dispatch levels, acuity guidelines, are all really important areas for us to be building toward consensus around and sharing information across programs to be able to identify some of these best practices. I also think it is wonderful and very much needed routinely for mobile crisis services to have some provision for follow-up afterwards. We know that one of the weaknesses in our systems typically has been to have kind of a one and done approach to a crisis, as though when somebody walked out of the emergency room, or when the mobile crisis team left, or after the hotline call ended, that the risk was completely gone. We know that's not the case. We know there's a need for follow-up. We know there's a need for ongoing, connection. And then finally, it's great to hear about the interaction with 911, how this is dispatched from 911, from a 911 PSAP, how that is being experienced by those doing the mobile crisis, and how that model is working well within Fairbanks. So overall, just loved hearing about this great work going on.
Great, thanks, Richard. And now I'm going to bring in Dr. Denny Morrison, who is a consultant and former chief clinical officer at NetSmart.
Thanks, great job, Christine. You guys are doing some wonderful work up there. Your stats are wonderful. I'm a real data guy. So I had some questions for you. I'm curious about, and you may have touched on this, I was a little bit late logging in due to user error. What since you have worked in other crisis systems in the lower 48, how is this different? What is unique about how the challenges that you have to face in Alaska that you didn't have to elsewhere?
Yeah, so Katie mentioned this. She's part of the Alaska Mental Health Trust, and I've been working with them. So when I worked in Austin, Texas, and so our agency had, lots of other options to bring individuals to. We had respite centers, we had short-term crisis stabilization, we had that piece. We're building that up in Alaska, but as of right now, we don't have a lot of options other than hospitalization. And so it's been really different. We've had to be creative. I think way more involved. And also we're ramping up our outpatient. So we have same or next day psych appointments to get people in. So we've really been trying to be creative, but it definitely has been challenging because the lack of options for those that are in crisis other than the hospital.
Well, I would have, before I asked the question, I would have guessed that kind of related to what Richard was saying is that the access to service, the kind of ability to get to people, both in terms of the rural nature and also, particularly in the winter, that I would think that trying actually physically getting to people would be a challenge. Is that true?
Right now we're in the Fairbanks area, so it hasn't been too difficult. There was 1 or 2 days where cars were stuck in the middle of the road because of snow. And so that presented a unique challenge, but generally I think that Alaskans are very resourceful and they figure it out. And so we just keep going despite kind of the weather or the cold. It just, it truly does get -40 and you just put on a lot of coats and scarves and you keep going, so.
Well, kudos to you. In my title mentioned that my background is NetSmart. I'm obviously got an interest in data and technology. How do you document these services both at the point of crisis and on the follow-ups?
Yeah, so we just put them in our ECR, but also it's great going through 911 because they have such a robust system for keeping the stats. That's why we've been so excited to partner with them, because the response time, who we're interacting with, the time from call to getting on scene, the time on scene, it's just been so helpful because they have that system in place to help us with some of those additional stats. So it's been exciting to be a part of that system.
And so clinically, when you gave a breakdown of the disposition of folks clinically, what kind of diagnostically or problem areas, what's the breakout of the population that you've been surveying? I noticed you mentioned a couple of people who had a history of schizophrenia.
Yeah.
I'm just curious about what does it look like clinically, the people that you serve?
Yeah, so actually when I was asking them, the number one kind of presentation is co-occurring. So we've bipolar disorder, schizophrenia, but then also struggling with substance use. That's been the top. I was really questioning the 88% because I know that's just a very, very high number. So I was trying to do a deeper dive to understand that. And what they had said is quite a few of the individuals just have such high case management needs. And so by being able to divert them from the emergency system, then we're able to really link them to what they need. And so it's a new service. So I think that, maybe we may see it go down just a bit, but we've seen lots of just case management, needs support with housing, get connected to benefits, all of those things. So
Cool. Well, Laura's going to jump in here. I just wanted to say, I'll bet you guys are now the new best friends of the police department.
And I think of the crisis jam, there's so many questions in the chat, but I do want to go to Nakia, I believe, who has your hand up. Feel free to come off of mute and turn on your camera.
Hello, everyone. And yes, my name is Nakia. I'm in Connecticut where it's cold most months. So I'm really excited to hear from you today. We just rolled out our first community support response team. And I am a bit concerned and just wondering how you handle homelessness. We don't have enough shelter beds for the amount of people who are in crisis and homeless. And when we respond to them, we just don't have enough places to put them. So what are you guys doing in such a cold area for your homeless population when you respond to the crisis? If you could offer any help or guidance in that, that would be great.
Yeah, so I think it's hard, just I don't know where you're coming from, but the population is pretty different. So we have about 30,000. In the winter, we've been able to successfully bring them to shelter, or like we saw in the success story, really focus on getting them housed. The reality is we still do have a significant homeless population in Fairbanks, and that's very scary. When it's -40, we have warming centers and other kind of resources that we can link them to. So that's obviously top priority when it's so very cold.
Great. Well, this has been a really great discussion. I know there's a number of items we weren't able to get to, so we'll just have to have you back for an update. And also, if your state is leading any innovative items related to crisis services, feel free to reach out to us. Always happy to feature what states are doing. So thank you so much, Christine, and our roundtable.
Christine, this is Denny. Just a note. If you do need any technology consultation, happy to come to Alaska. Would love to come up there and see you guys. But you guys are doing really great stuff there. Congratulations.
Great, thank you.
Yes, just not when it's 40 below. I'd like to come when it's above 0. So now we're going to move to our crisis hot seat, and I'm going to bring on Steph Pasternak from NAMI, and we're going to continue this theme of homelessness and individuals who are unsheltered and in crisis. So Steph, this comes directly from Tom Insell's book, that chapter that we referenced in the quote, and it's homelessness is more complicated than our stereotypes. Some are families living in our car, some move in and out of shelters, and some live years under a bridge or in an encampment. So the question is, hard to avoid seeing in California, about what percentage of the nation's unsheltered homeless live in the state? And so, yeah, want to turn it over to you. You have the option to phone a friend, bring someone on to talk to, poll the audience.
Great. Yeah, no, this is a tough one. Definitely, I love the question, because definitely agree homelessness is much more complicated than that point in time count that happens each year. A lot of folks are transient and moving and otherwise, unstably housed, and much more complicated than just the folks that we see every day that might be living on the streets. So would love to poll the audience. Oh, sorry, did I already run out of time?
No, you've got your poll results right here.
Oh, okay. So the audience thinks it's B, 40%. I have personally never lived in California, so I know that is a high concentration. If I can actually phone a friend, I know Dr. John Sierra's on the line. My instinct is maybe to go with the audience's answer of 40%, but I'm wondering if maybe that's even too low. Dr. Sierra, what do you think?
I was thinking either 40 or 50%. I was leaning toward 50%, honestly. Wisdom of the crowd might be better, but yeah, I was leaning toward 50%. Audience says 40%. I'm thinking it's one of those two.
Okay, all right. Well, maybe I'll lean towards the expert opinion and actually choose C.
All right, let's see. Let's see the results. This one was actually really tough. So yes, Steph, it's 50%. Good job relying on the expert. And if we go to the slide here, in that chapter, Dr. Insell references both. It is the high cost of living in California, but also, it's a very attractive locale with a temperate climate. And so that all contributes to what we see in terms of unsheltered folks in California. And I think we were trying to do the math earlier in terms of the percentage of California's population relative to the whole nation. It's still, I think, disproportionate unhoused individuals in California. So thank you, Steph. You have passed the hot seat, and we'll come back to you for the state update. We keep us going. I am going to turn it over now to Stephanie Hepburn to discuss the latest Crisis Talk article. Steph?
Thanks, Laura. So I interviewed Baton Rouge Police Chief Murphy Paul, and we chatted about the spike in mental health and substance use emergencies in the city and how law enforcement has nowhere to turn or has historically had nowhere to turn in Baton Rouge, but jail or the emergency room. Chief Paul, if you're on the call, if you can talk a little bit about the challenges you and your officers were experiencing, and also how you helped push for a crisis stabilization facility in Baton Rouge.
Hello, thank you. How are you? Can you hear me? Can everyone hear me?
Thank you for coming.
All righty, yeah, thank you. Well, we will. all be on the same page. I was blessed with this opportunity when I took over in 2018, and obviously mental health was an issue. So through the leadership of our mayor president, Sheridan Weston Brum, she was able to get our business community behind us in our efforts. Not just the business community, the district attorney, myself, the coroner, and our sheriff. So all law enforcement leaders sat down under her leadership. They were very deliberate in our efforts to get a tax pass. And we began the campaign, and the campaign was Vote Yes for Mental Health. So we started the Vote Yes for Mental Health campaign. Obviously, there was some polling done. We knew what areas we had to work on, but what we knew was that everybody in the community, no matter what class they were, doesn't matter what part of the city you live in, everyone can relate to mental health challenges as well as addiction. So we were able to tie the addiction and the mental health issues into our messaging. And we went to the voters and we asked for a mental health tax, and it passed. Even though some thought it wouldn't pass, we were able to do that, which actually formed the funding source for us to create a nonprofit, the Bridge Center for Hope. So we created the Bridge Center for Hope, where the services will be provided. And we've been supporting it ever since. So that's something, just to get the community to tax themselves for an issue, and it passed overwhelmingly. And it's excited about the potential of where the Bridge Center is going.
You mentioned also drop-off times, how vastly different it was even from your own estimations. I think you said drop-offs have been less than 4 minutes. Is that right?
Yeah, we just did it. I think we had I sit on a board, and the average time for drop-off for a law enforcement response to the Bridge Center for Hope for someone who was experiencing a mental health crisis was right at about 3.5 minutes. Was the average, 3.53 to be exact. Now, you said prior to that, that was about 4 hours to 12 hours. Before we had the Bridge Center for Hope, the only option was the hospital or jail, neither one who dealt with the issues. So, especially in challenging times today where we have our issues with vacancies in law enforcement, recruitment and retention challenges, I tell you, to have those resources now to go out there and do work, the Bridge Center came at the right time.
Thank you so much for hopping on the call with us. I appreciate it.
Yes. And look, thank you. I got to say this. I was taking so many notes. Thank you, Alaska. I'm telling you, I was like, yes, because we're in the process of creating our mobile response team. And I'm just sitting there writing everything down. So we will be giving you a call in Alaska just to hear all the great work that's going on up there with your mobile response team. Give me some highlights that I'm going to point out in our next board meeting.
Great. Thanks, Stephanie. Thanks, Chief Paul. And Chief Paul, feel free to invite your law enforcement colleagues to this learning jam. We welcome their insight. So I'm going to turn it over now to, again, Dr. Richard McKeon to give us an update from SAMHSA.
Thank you, Laura. So several things that I would highlight that is going on. So the 988 messaging framework was just released by the National Action Alliance for Suicide Prevention. And this group was co-chaired by SAMHSA, by Kate Gladys, our 988 communications lead. So we would urge you to check that out. Also, a reminder that we now have on the SAMHSA website, we have samhsa.gov/988, which is available with a variety of really important pieces of information. So if you haven't had a chance to check that out, please do. And then finally, tomorrow we will have our national convening on 988 readiness. And do we have a separate slide for that, Laura? If not, I'll just go over it verbally.
I don't believe we do. That has that information. So if you could share that verbally, that would be great.
Okay, all right. So the convening is tomorrow between 1 and 5 Eastern time. It will include a federal panel. It will include audience specific workshops as part of this, focusing on the 4 key audiences or stakeholder groups that we've been working with, namely states, tribes, and territories first, behavioral health care providers, crisis contact centers, and 911 public service answering points. And these will be going over the operational readiness criteria that have been developed, as well as an overview of the playbooks for each of those areas, with the actual playbooks being released just in the next couple of weeks. And Laura has helpfully sent the registration link for the convening. So we're very grateful around that. So a lot of activity that is going on. We're, of course, all waiting for the release of the president's FY23 proposed budget. And when that comes out, we hope everyone will look at that closely and do what they can to support. So that's what I have.
Great, thanks, Richard. And I just want to express how grateful Vibrant is for our partnership with SAMHSA in being the administrator for the Lifeline and working with Action Alliance on the messaging framework. So just kudos to you and the team there, because I know you all are working so hard.
And I'm putting in the link to the messaging framework into the chat right now.
Yes, perfect. And I think you've teased what we may be hearing from Sarah Corcoran later around that FY23 budget. So at this point, I'm going to turn it over to Dr. Brian Hepburn of NASHBA to give us an update.
Thank you, Laura. And I just want to say, no matter what David Covington says, I think you do a great job. So thank you to Laura, and thank you to Christine. That was a very interesting presentation. It's really nice to see what's being done in Alaska. Want to also piggyback on what Richard just talked about. We've been privileged to work with SAMHSA on the convening. We think that this will be very helpful to various stakeholders on preparing for 988 and the changes that are going to come about as a result of 988 regarding crisis services. Want to thank Dr. Delphin Rittman, John, Richard, and team. They've done a really great job of working with the stakeholders, and we hope as many people as possible can join the convening tomorrow. Next slide, please. I wanted to highlight a couple of papers on homelessness. One was by Kevin Martone, and Megan is putting that link in the chat. Also a paper and presentation by Kevin Lindemood and Barbara DePietro on focusing on homelessness. They worked at Healthcare for the Homeless in Baltimore, a great facility. I also wanted to just say real quickly, you know, PAC teams, the assertive community treatment teams, they've worked for years in the space of homelessness, taking care of individuals wherever they are, under bridges, et cetera. And they've been excellent at helping people deal with crisis, recover from crisis, prevent crisis. So I wanted to give a shout out to the PAC teams. Thank you very much. That's me.
Thanks, Brian. And just shout out to your entire team. You guys are working very diligently as well. And Vibrant is so, I keep saying grateful, but that's the first word that comes to mind for our partnerships and making sure that states have what they need as we make this transition. So I am going to now turn it over to Sarah Corcoran from Guide Consulting, as well as Joanna Rosen from AFSP for some federal updates.
Thank you, Laura. And as Dr. McKeon mentioned, we are expecting the FY23 President's budget expected now as of next Monday. Is the 28th is the date that we expect to see that and to see what the budget request numbers from the Biden administration are for the FY23 budget and appropriations process. That is not any sort of final number, but it does help to guide the House and Senate committees as they start their process of what the priorities are. So we'll have a new slide next week, replacing this old one to kind of start the FY23 process. But for now, I will turn it over to Joanna from AFSP with a hearing update.
So the Senate Health, Education, Labor, and Pensions Committee is actually, I believe, currently holding a hearing. If not, it has probably just recently ended on SAMHSA reauthorization, mental health, substance use disorder programs, and we're excited to see what comes out of that. Looking forward to that, and like Sarah said, looking ahead to FY23.
All right, great, thank you. And now I'm going to turn it over to Dr. Eric Rothwell-Yon to talk about the 988 Implementation Act.
Hi, everybody. Great to be able to see you all again. So we're very excited that our 988 Implementation Act has now been introduced. It was introduced at the virtual press conference last Thursday. We got quite a bit of media attention, so thanks as well to Karen for linking those articles. The bill number is HR 7116. We have a lovely informational packet that our communications team put together, so I will link that in the chat as well, which I think has a really good amount of information on the bill. The couple of items that I wanted to highlight on this, so we're really trying to push this forward. Congressman Cardenas, who's leading the bill, sits on Energy and Commerce, and so we're working with the committee to try and advance this. But I appreciate any support that you all are able to do in reaching out to your members of Congress, to let them know that 988 is important and that it needs more federal support and to be successful. One thing that we're still seeing as we're having discussions is that many members of Congress are under the impression or assumption that 988 is done at the federal level and now it's the state's responsibility. And we're trying to say, wait a minute, it needs to be done in partnership if it's to be successful. And that there's much more that Congress can do to make sure that everyone has access to 988. And when people call 988, they have access to crisis services. So again, I will link those items in the chat, as well as my email. Feel free to reach out if any questions. Thanks, everybody.
Perfect. Thank you so much, Eric. And I just want to thank you as well. Just appreciate all that you've done to get us to this point of introduction. That is no easy lift in Congress these days, but this is so important. And as you mentioned, it's so important that everyone is at the table. It is not the responsibility of just one level of government, but it will take everyone at the table, fed, state, local, private, public payers, but it can be done. So thank you so much, Eric.
Yeah. Just one quick item on that point that reminded me, if I forgot to say, we're really appreciative to all the help that experts in this forum and across the country have been provided. We got input from nearly 100 organizations in all 50 states, law enforcement, civil rights groups, mental health advocates, TA from multiple agencies, as well as the National Indian Health Board. And other veterans organizations. So we've really done a lot of work for months putting this all together, and really happy to see it now introduced.
Dr. McKeon, did you want to add anything?
Well, I was just going to ask, Ara, and thank you for all of your incredible work on this bill. I was going to ask if there have been any conversations yet with anyone in the Senate about introducing a companion bill.
Yeah, so we have had multiple conversations. We are hoping that we have a Senate companion locked in that will be introduced in the next few weeks. Right now, they're very slowed down with the senator sits on the Judiciary Committee as well as Foreign Affairs, and that has been a busy few weeks for them. So that's what we're hoping. Some of the earlier discussions we had got slowed down because the Senate's vision of their mental health packages this year was in more of a agency by agency, authorization by authorization. And we felt that 988 needed cross support and couldn't just be done in a single agency type of authorization. So but hoping to make progress on that.
Thanks. And again, Vibrant is very happy to add our voice there and offer our support for this legislation. And I see folks are offering other suggestions in the chat. So just again, make sure that you're talking to your congressional delegation if this is something that you would like to support and tell them about this legislation. So let's move forward to the next slide, please. And I'm going to turn it over to Steph Pasternak, who did so well at the hot seat today, from NAMI, as well as my colleague, Jordan Pantalone, who's the newest policy manager within Vibrant, to give us some state level updates. Jordan?
Thank you very much, Laura, and apologies in advance. I'm having some technical difficulties with my camera, so you're probably seeing a black screen for me. So a few things before I hand it over to Steph. Just want to flag a couple of bills that have been introduced in the past couple of weeks. 2 omnibus bills, one in Minnesota, one in Connecticut. Both address some larger mental health initiatives, but do include some language on 988, including a fee. So in Minnesota, that would be capped at a 12-cent fee, and in Connecticut, that would be capped at a 75-cent fee. Just flagging that those have been introduced, and we'll certainly update you as those move along the legislative process. And just kind of a more general update, we are seeing states kind of towards the end of their legislative session, and as that happens, some of these funding mechanisms are kind of shifting towards budgetary means. So we are beginning to track what states are planning to appropriate for 988. Most recently, I think a week or two ago, we saw New Jersey set aside $12.8 million for 988 implementation. If folks here do have any insight to what your state might be planning on giving for 988 through the budgetary process or other appropriations, please do let us know, as we are starting to track that. So I'll turn it over to Steph.
Yeah, thanks so much, Jordan, for that overview. And being mindful of time, I'll just highlight a few more states. Notably, Kansas's 988 legislation recently passed the Senate on Monday, specifically the Senate version of that legislation, which is Senate Bill 19. It had already passed the House, so now this just needs to head to conference committee. Originally, that legislation had a fee funding component, but that has switched over into a $10 million allocation of state general funds. And also, I wanted to note Mississippi has, you've seen its color change to that lavender color because the governor recently signed a 988 study commission bill into law. And this commission that will be formed will be responsible for making recommendations to the legislature and the governor's office about how to fund their 988 system for the long term. A couple other states to note. Ohio's House Bill 468 recently passed out of its first committee. This bill adds certain 988 state definitions into code, also creates a 988 trust fund. And I will also note Maryland's 988 legislation. Both versions have passed out of their original chambers. This creates a 988 trust fund and also mandates an annual appropriation in support of 988. And from there, I think I'll just kind of wrap up the state update, turn things back over to Laura.
Thanks, Steph. And I also just want to note here, and it connects back to what Chief Paul mentioned around that fee they assessed at the state level or their local Baton Rouge level. And they were worried about, well, this won't pass, it will be seen as a tax. And NAMI has done great work to survey and find that I think it was 75% of individuals would support a fee on their phone bills to support suicide prevention and this 988 implementation, the crisis centers and the rest of the continuum. So just if we have any legislators out there, and I know we do have a couple, this is so important. And I think we can't underestimate how folks will react to this, because I think there is an acknowledgement that there is a collective drive to work on suicide prevention and all chip in. So as Steph mentions, there's no deadline in enacting that fee. And so want to make sure that folks know that there is public support for that. All right, so let's go to the next slide. And again, these are our state 988 implementations cards, sort of like the baseball cards, where you could see both what they have anticipated in terms of cost and revenue generation from any fees. So we will be continuing to add states to these cards, so keep an eye out for that. And let's go to the next slide. And I'm going to turn it over to Paul is not here today to talk about the crisis calculator, but if Kana is available, I'd like you to come off of mute and turn on your camera to tell us about this. And if you're not here, then we'll just give it a beat and keep moving. All right, Kana may not be with us today. I know she is planning to do a full presentation about this crisis calculator, but it is available there. And so let's keep going. All right, so we have, again, episode 3 is available. That is Tanja Miles' presentation on moving America's soul and suicide. She did speak to the Crisis Jam, I think about a month ago. And I believe Dr. Thomas Joyner and Ursula Whiteside will have their videos released soon. So we are very excited to see that. Let's keep going. All right, and as mentioned, Kana will be here next week on the Crisis Jam to talk about the crisis calculator, followed by kids crisis care in Connecticut. I know there's been a lot of interest in youth crisis care, so that's going to be really exciting presentation, along with the role of medication in crisis care, lessons from poison control. SAMHSA comes back to us for a part 2 of 988 operational readiness, April 27th, followed by Vera Institute, crisis opportunities from CMS, and medical comorbidity and crisis discussion. So I just want to thank everyone for joining us today. Dr. McKeon, do you want to leave us with any closing thoughts?
Well, I will just mention one thing. When SAMHSA wrote our report to the FCC, as we were asked to do under the Hotline Improvement Act, to weigh in on the potential impact and effectiveness and need for a 3-digit number for suicide prevention. We indicated that we thought that a 3-digit number had the potential to play a pivotal role in transforming behavioral health crisis services in America in much the same way that 911 played a pivotal role in improving emergency medical services across the country. And obviously, it's not the number itself, it's the number itself, the message it communicates about accessibility, and the way in which a delivery system can be organized around it, that I think has made all of the difference for emergency medical services. And it is incredibly heartening to see how that in fact is coming to pass, and how there is such an incredible level of engagement and increased engagement by so many public and private stakeholders. We are on our way, and we are so glad for everybody's engagement, involvement, and commitment to this incredibly important mission.
Thanks, Richard. That is very well said. This work is so important. And I'm not a clinician, I'm a policy person. And so just to watch you all work day in and day out, especially our Lifeline crisis centers doing the work all across the country, 24/7, 365, just really honored to be a part of this transition with you all. So with that, I will close us for the day, but thank you so much for spending this hour with us and look forward to seeing you all next week.